Thank you. Good evening, everyone. As always, Ali, thank you for your kind introduction. So, as Ali said, I'm Ketan Sheth, a councillor in Brent and also the chair of Northwest London Health Scrutiny, covering all 8 Northwest London boroughs. Welcome to this evening's seminar about HIV, and we have one of NHS England's experts, as Ali was just saying, who also works for sexual health services at CNWL, where I am also the lead governor. The story of HIV is decades-long one, from very dark, bleak beginnings through massive compassion shown by staff on the front line. The creation of movement of those most directly affected, and incredible research programs generating quite miraculous medical breakthroughs. The progress has been stunning, and there is more to do. And our guest speaker, my friend, Dr. Laura Waters, will be saying much more about it, all in a usual captivating way. Award-winning programs like Is a Scene took us back to those terrible early days from which a magnificent movement arose. What is now known as co-production was successfully pioneered around HIV and AIDS. One of those pioneers was my friend, Cllr Sanford, who died last October. He lived with HIV for 40 years, and his partner died from an AIDS-related illness. Cllr, whose birthday is tomorrow, and we mark his birthday early this evening, and his memory and honor his legacy, personified this movement. He was a peer support worker for those recently diagnosed with HIV, and he pursued and pressed and persuaded for better treatments and care for all those living with HIV, but also for a world that understood people better and valued everyone without discrimination or stigma. So, in remembering Cllr tonight, we salute mighty fallen oak he was, but he would also smile and say, "Come on, let's get on with it." So we shall. So first, we are joined this evening by Cllr's sister, Zoe Everingham, all the way from Australia. In fact, it's early hours, and I'm so pleased that Zoe has got up so early in the morning to be with us this evening in London. I'm going to invite her to say a few words before I introduce our friend, Dr. Laura Waters, as a tribute to our dear friend, Cllr, as we fondly remember him. Zoe, thank you very much for joining us this evening, London time.
Thank you very much, Ketan, and it's wonderful to be here with you all. One of the things I remember about Cllr, growing up with him, and also, of course, in his years of advocacy for HIV, was his sense of every small step matters. In the early days, it was tough, and I remember many of the very degrading things that people with HIV had to go through in the 80s, and it was heart-rending to hear those stories again. But Cllr was very determined, and I know that in his later years of advocacy, it was an absolute blessing for him that he could then work in a space where this kind of well, almost atrocities against people could be spoken about openly, and that the whole environment around HIV and the perceptions could be changed. And one of the things that Cllr was very cognizant of was that the change could occur not only from advocating those at the top, you could say, who had some form of authority or power, but it could change by helping every single person, one person at a time, those who were newly diagnosed with HIV, that the myths that we heard propagated in the 80s could be busted, and that there was an incredible future for every person, and that you could live really well with HIV. And he was a walking example of that. And so since his death late last year, I've been reminded that as we come to understand that we can all live well in our lives, we are then in control of passing that message on to others. And so it's wonderful that you are all gathered here tonight from across the world for wherever you are, knowing that not only is this message for you, but this message is also for others through you. And this was, I think, one of the things we celebrate about Chris's work. So please enjoy what Laura has to share with us tonight, and hold that dear in your heart, but also make sure others know about it too. Thank you very much, Laura and Ketan.
Thank you very much. So we really am grateful to you for joining us. I know it's early hours in Australia, but really am grateful to you. Now, I'm just looking at all our friends on the screen, and we are joined also by Professor Dorothy Griffiths, who is the chair of CNWL, where Chris Sanford was one of the governors. And just very quickly, I know I'm putting you on spot, Dot, but would you like to say a quick 1 or 2 words before we go to Laura, please? Thank you.
Let me say, Ketan has put me on the spot. I had no warning of this, but it is a huge privilege to be asked to say a few words about Chris. He was amazing. And one of the most amazing things about him was he was so positive. He brought such energy and positivity to everything he did. I don't know if positivity is a word, but he brought that to everything he did. He was a wonderful governor in CNWL because he was always positive about what we were doing. And I don't need to say, because everyone will say it, what a champion he was for people with HIV, not only through his own example of living with it, but that he didn't let the rest of us forget what the battle was. He kept the history, I think, almost single-handed. He's kept the history of HIV alive, and it's a very, very important history, actually, partly because of some of the things you were saying, Zoe. So thank you for letting me make my own tribute to Chris tonight, and it's fantastic we're having this seminar. Thank you, Ketan, and everybody who's pulled this together.
Thank you very much, Dot, for allowing me to put you on spot. Thank you very much. So from one CNWL colleague to another CNWL colleague, Dr. Laura Waters. So as Ali was saying a few moments ago, Laura is a physician, having trained at Charing Cross and Westminster Medical School, which is now part of Imperial, of course, and is a consultant specializing in HIV and AIDS medicine at Mortimer Market in London. She is the chair of British HIV Association and advises the NHS England on HIV treatment. Laura is also a regular contributor to Boys magazine, and throughout the recent pandemic provided regular advice to HIV plus communities. And this evening, we are very lucky to have her with us. And so without a further ado, I'm going to ask Laura to please provide us with an overview about HIV and AIDS care, please. Thank you.
Brilliant. Thank you so much. Right, let me just now show my IT ineptitude by struggling to share my screen. Maybe I'm not. I'm hoping, can you now see my first slide?
Yes, thank you.
Amazing. Thank you so much. What wonderful words and to try and follow. I've worked at the Mortimer Market Centre since 2012, and Chris was definitely part of the furniture of that wonderful building. Our clinic to my knowledge, actually still remains the only clinic to directly employ peer support workers. A number of HIV organisations work with peer support organisations, but actually by embedding people accessing HIV care within our service decisions, we really do put people living with HIV at the centre of what we do. So Chris taught me more than I could fit into a 2-hour meeting, if I was to tell you everything Chris taught me. A truly fabulous friend and colleague, and somebody that I think about daily, but he leaves an incredible legacy. And I think the point about not forgetting the history is so important, because when we forget the history of events, then things can go bad again. So it's really important keeping that knowledge alive. So without further ado, who am I? So you've already heard, I'm an HIV and sexual health doctor. I've worked in HIV and sexual health since 2002. Which is 21 years, and as I mentioned, been a consultant at the Mortimer Market Centre, which is CNWL's London service since 2012, and I've led the HIV service since 2018. We are actually the second biggest HIV clinic in the country. We've got about 5,800 people living with HIV in accessing care in London, and about another 800 people in Surrey. So I was the chair of the British HIV Association until last month. I did that for 3 years, and now I'm the National Specialty Advisor to NHS England about HIV care. So very simple talk, and it's not that many slides, I promise. I'm going to talk about the history, I'm going to talk about where we are now, then I'm going to talk about the future, and then just finishing with a couple of quite sobering closing thoughts. So HIV actually first emerged in humans back in 1920. It often takes a long time to truly understand and develop clever enough tests to know this. So it was in 1920 in the Democratic Republic of Congo that the virus is first thought to have entered humans. But it wasn't until the 1950s that we started seeing much more transmission, and that was due to urbanization. It was due to easier access to travel, rail networks, for example. Where you see hubs of industry and travel, that's where the sex work industry tends to grow. And the element that's probably underestimated in the history books is the role of medicine, the role of not using different needles when administering vaccines and treatments and the like. So that what we call iatrogenic medical procedure-based transmission was also very important. Now, the first proven case of somebody with HIV, although we know it entered humans in 1920, the first absolutely proven case of HIV is 1959. That was a relatively recent discovery, and it was through testing of old post-mortem samples that have been stored. So the first proven case was 1959. So, however, like many things in life, it wasn't until this devastating condition hit the shores of a high-income country that people started to take notice. So in June of 1981, there was this now infamous series of reports of young gay men dying of conditions that somebody with a healthy immune system would not be affected by. The first case in London was in December of the same year. And in 1983, the CDC, big health body in the US, came up with this list of people who were at risk of AIDS. Now, to clarify now, as I'm sure many of you know, HIV and AIDS are not interchangeable terms, and we tend not to use the term AIDS when describing people. So HIV is the virus. AIDS is a constellation of infections and cancers and symptoms that will only emerge if somebody doesn't get treatment. So by far the majority of people with HIV today will never develop one of the conditions that sits under that AIDS umbrella. But 1983, things weren't quite the same in terms of terminology, and the CDC in the US came up with 4 groups of people who are at risk: homosexuals, haemophiliacs, heroin addicts, and Haitians. And that became known as the 4H Club. And you can see how very early on those seeds of stigma, which are still rife today, were sown. And it was terrible. People died lonely and painful deaths. This is a picture from a series by a photographer called Gideon Mendel. It's exhibited regularly, and just recently an exhibition finished at the Fitzrovia Chapel, very close to our clinic. And there's some debate, actually. It was interesting, even in our own clinic, when we put a poster up with a similar image, some people felt it was no longer appropriate. Why are we harking back to these bad old days? But actually the consensus, including from our current peer support workers, was it is important to share this history, and so it is important to promote exhibitions like this. And then, as Ketan's already mentioned, the programme It's a Sin really brought those early years of HIV to an audience who didn't live through it. There are so many people who never saw, I'm sure many of you remember the gravestone campaign that was put out, and that remains the only time nationally there's been a big campaign about HIV. And for those of you who didn't see it, it was on every television advert break. These are back in the days when we only had 3 or 4 channels. And it was gravestones, it was icebergs, it was do not die of ignorance. It was narrated by John Hurt. I remember I was 12 at the time and thinking, oh, I will never have sex. I would die, because that was the message. Now, we look back on it now with horror, but at the time, based on what we knew, it was probably quite effective in preventing some people from acquiring HIV. It's certainly not a campaign that we'd run today. But many people, of course, that was a long time ago, will not have lived through that. So the TV series It's a Sin brought that history back to so many. And if we look at the 1980s, it was 1987 that the very first HIV drug was approved. So it was about 6 years from the first cases appearing in the US, London, and then other parts of the world. And the first HIV drug was approved. It was actually a repurposed cancer drug. And we saw during COVID this concept of repurposing older drugs used for different things for a new condition. And then throughout the early 90s, we had more drugs coming along in the same family, but the problem is that the benefit was only ever short-lived. These were drugs where it was quite easy for the virus, because HIV is a clever virus and it will mutate and develop resistance to drugs quite easily. So the benefits of these drugs tended to be fairly short-term. The other difficulty is they were associated with really severe side effects, and some of those were quite stigmatizing. So some of these early drugs, including this drug zidovudine, could cause really quite marked fat loss. So people would lose all the fat in their faces. And that's something that many people who've survived those early years still live with today. But it was the mid-1990s that were considered the turnaround for HIV treatment. So in 1995, the FDA, the body that approves drugs in the US, approved for the first time a drug from a different family. And this enabled us to use something called combination therapy. So we now had 2 families of drugs, and this was swiftly followed by a third. And by combining different drugs from different families in a particular recipe, we could keep HIV controlled. And this is what happened. So this is a graph looking at mortalities. These are deaths amongst young adults. These are 25 to 44-year-olds in the US, and it goes from 1987 out to 2010. And you can see along the side different causes of deaths in that age group, but that red line that's going up and up and up and up was HIV-related deaths. So you can see prior to the mid-90s, there was this kind of exponential increase in HIV-related deaths in young adults. But then by using these combination treatments and being able to suppress the virus, to stop it replicating and allow the immune system to recover, you can see the effect it had. And there was this drastic drop in HIV-related deaths that continued to improve as treatment got better. And I still think, I cannot tell you how many times I've presented this slide, but every time I see it, I think it's a real reminder of just how important that drug development was. Now, it wasn't easy. So I've already mentioned the first families of drugs. The next family wasn't particularly nice to take either. It was multiple pills, multiple times a day, some on an empty stomach, some with food, lots of side effects. I mentioned the fat loss, but people could have life-limiting diarrhea, painful inflammation of the nerves, all sorts of side effects. But ultimately, these drugs saved lives. That's an example of a chart we still fill in today. We still refer people for treatment to help deal with the visible effects of fat loss, really disabling diarrhea and vomiting. Some of the drugs could cause severe rashes, which in some cases would lead to people dying from very serious allergic reactions. Thankfully, something that we just do not see anymore. So where are we now? So these are the figures for England. And so in England, we have about 86,000 people accessing HIV services. There's about 110,000 people across the whole of the UK, but that includes about 1 in 20 people who don't know they are living with HIV. So we really need to improve testing. And recently in London and some other cities, we've been doing routine emergency department testing for HIV to try and diagnose those undiagnosed people. So you can see the number sort of goes up slightly now. We've seen a reduction in new cases of HIV, which I'll show you in the next slide. But the other thing to point out is you'll see from those colours that about half of all the people getting HIV care in England are now 50 or older. And as we reduce the number of people acquiring HIV through making sure people are tested, they're on treatment, and for people at risk of HIV, we can offer a number of ways to prevent it. The population of people living with HIV will naturally get older and older, and that provides a lot of challenges for care services. This is again data from England. It looks at the number of new HIV diagnoses, that line that's going down, and you can see that it's been going down year on year. That's for a number of reasons I've mentioned already: better testing. Pretty much everybody diagnosed with HIV goes on to treatment. And as you'll hear shortly, if you go on to treatment and your viral load is undetectable in your blood, you cannot pass HIV on to other people. And we've also done a better job of getting prevention. You may have heard of PrEP, or pre-exposure prophylaxis, which is using HIV drugs for HIV negative people to reduce their risk. And it's highly effective at reducing the risk of them acquiring HIV. Now, the drop hasn't been equal. So what this graph shows us is that the drop in new HIV cases has been most dramatic in men who have sex with men. But amongst heterosexual men and women, actually, it hasn't gone down as much. And again, a lot of that is around accessing testing. Sexual health services still provide the bulk of HIV testing, though we're getting a bit better at offering it in emergency departments, as I've mentioned, but primary care and other health services. But I think we need to do better. And that's why things like HIV Testing Week, which happened recently, are really important, where anyone can go online and order an HIV test to do at home. So some key figures I've mentioned: in England, 1 in 20 people don't know they have HIV, and the problems there are for their own health, because if you present late with an already damaged immune system, you are at a higher risk of getting sick, and you're at a higher risk of dying. Once you're on treatment, that thankfully disappears. 99% of all people are on treatment, and 98% of people are undetectable. That's how we measure whether the drugs are working. And if you can't find the virus in somebody's blood, that's undetectable, and it means the treatment is working well. And these figures are amongst the best in the world. So we are very proud of what we've achieved in the UK. Globally, however, the picture isn't necessarily the same, and the numbers are much, much bigger. So just to give you a couple of figures, globally, since the start of the HIV epidemic, more than 84 million people have been diagnosed with HIV, and 40 million people have died from conditions related to advanced HIV. In 2021, 38 million people living with HIV, 1.5 million new cases, and we could easily reduce that if we rolled out prevention to everyone who needed it. 650,000 people died of AIDS-related conditions, and only 28.7 million people are on treatment. So you can see, unlike in the UK, where we have the fantastic figures of 98% of people being on treatment, my maths isn't brilliant, but there's a big gap between 38 and 28 million people. So 10 million people not even on HIV treatment. Although I did do the math, 75%. So in terms of the treatment we're able to offer, I'm not going to go through lists of drugs, but for many people, we can offer them just one pill once a day. And for people needing to take medication every day, to be able to take just a single pill instead of multiple pills, particularly more than once a day, is a huge advance. Fairly recently, we've got access to injectable HIV treatment. And this means that people, instead of taking a pill every day, can come to the clinic every 2 months have a couple of injections. They're quite big injections, one in each buttock, but those treatments work pretty well. And for people who are struggling with that daily reminder, they might live with people who don't know their HIV status. They might find it difficult to take tablets. To be able to come in and have injections can be life transforming. Normal life expectancy. Somebody with HIV who's on treatment that is working has the same life expectancy as the general population. That's been the case in the UK since 2014. There was a paper published showing that, but it's a message that still isn't necessarily established. And then U equals U, this stands for undetectable is untransmittable. This concept that someone living with HIV on effective treatment and an undetectable virus in their blood cannot pass the virus on to their sexual partners. Zero risk of transmission, and that's been transformative. Stigma is still an important issue, but this U equals U message has at least partially challenged it. And I don't know if anyone watches EastEnders, but it was very heartening recently to see Sam from EastEnders explaining U equals U in very similar words to which I've just used to someone living with HIV on the programme. Now, it's not all perfect. We know people with HIV are at a higher risk of a number of age-related conditions. Sadly, we're all at risk of various conditions as we get older. Kidney disease, bone disease, and heart disease are all more common in people with HIV, and some of the drugs we use can actually contribute to that. Some of the drugs we use cause weight gain. It's a very topical issue at the moment, and the difficulties of accessing the appropriate support for people who get weight gain on treatment is difficult. And also mental health issues. We know people with HIV are more likely and much more likely to experience anxiety and depression. And again, trying to coordinate care in an NHS that is always struggling for resources can be a challenging thing. Again, incredibly lucky to work where I do because we have an in-house psychology team, we have health advisors, and here again, the concept of peer support, concept of people living with a condition being equipped to support other people living with the same condition is so important. Now, I don't want to over-egg this. It's not all down to HIV or HIV treatment. All of these normal factors apply: smoking, unhealthy diet, excess alcohol, recreational drug use, lack of exercise, and other infections like hepatitis B and C and syphilis. They can all contribute to other long-term health problems. And we know on average that people living with HIV are more likely to have one of these factors than people without. Probably one of the most important drivers, though, are those sort of socio-economic drivers of health. I think COVID really shone a lens on the fact that many people through disadvantage have worse health outcomes based on housing, occupation, and education. And the other thing we cannot ignore is the impact of racism and systemic racism on health outcomes. And there's some really incredible work on that topic. Many people know much more about this than me, but again, another issue that disproportionately impacts people living with HIV. Now, the problem is there's still a lot of stigma. So this is an example of a survey that was undertaken just a couple of years ago, and it shows almost half of the people surveyed in Britain, it was several thousand people surveyed, would feel uncomfortable kissing someone with HIV. Now, we've known even the CDC who came up with that horrible 4H list all those years ago, even back then they knew that HIV could not be passed on through kissing. We've known that for years and years, yet people still have this fear. The survey showed concern around things like sharing glasses, sharing plates and cutlery, toilet seats, all of this utter nonsense that we've known has been nonsense. We're clearly not doing well enough if so many people in the general population are scared to do those normal day-to-day things with someone who's living with HIV. And it's not just the general population. There are so many examples of stigma in medicine. There are so many examples of inappropriate beliefs about the risk of acquiring HIV during an operation, the need to wear 2 pairs of gloves instead of 1. And that's something we're constantly trying to challenge. But I think one thing we have to accept, and this isn't always a very popular thing that I say to some of my colleagues, is HIV services are responsible as well. We've created a system where HIV care has remained very specialised. And in some ways, I think we've done people with HIV a disservice. I think we should have been integrating better with GPs and other elements of health and social care systems so that everybody had experience of providing care. And that would really, I think, help bust the myths and address the stigma. So what about the future? So I've mentioned injectable treatments. What we don't have yet, though, is an injectable vaccine or any vaccine. Every time there's a conference, there's a big news story about a promising vaccine, but it's a long way off. And again, I mentioned that HIV is a very clever virus and it hides from the immune system, because what you want for a vaccine to work is a clear way for the immune system to fight that infection. And we just don't have that for HIV. And I think a vaccine is a long way off still. The other thing we should have fairly soon is injectable prevention. So I mentioned that we've got HIV drugs for treatment, but injectable drugs for prevention are much more effective than what we have now, which is tablets. So hopefully that will be on the horizon soon. There might be implants. So this is an example of a contraceptive implant that just sits under the skin and provides effective contraception. Based on identical technology, we may in the next few years have HIV drugs that do the same. So instead of taking a tablet every day, or coming to the clinic every month, some will come to the clinic just once a year to have that implant replaced. I can't remember what that hammer's for, to be honest. I think that was related to cure, sorry, hammers for cure. And again, there are a handful of people who have been cured, a handful of people who've had bone marrow transplants for cancer treatments, where they've had radiotherapy, chemotherapy, and bone marrow transplants, where they've actually ended up being cured of HIV, but it's not a realistic option for most people. And bone marrow transplants themselves are a very complex treatment. So it's cancer treatment that happens to have cured HIV for a handful of people. Vaccines I've already mentioned. The challenges of aging I touched on, and this I think is the biggest challenge facing us, particularly considering that the potential stigma in some of the sort of social care services is something we really need to address to ensure people with HIV get the same care. And all of this on the background that we're going through a massive NHS restructure once again. So HIV care in England historically has always been delivered at national level, commissioned at national level. So NHS England are in charge of the funding. That's all changing over the next 12 months. And integrated care systems, these new developments for regions to sort of address local health needs, which should offer lots of opportunities. It's also a time of caution for us to make sure that those excellent outcomes aren't affected by NHS restructure. And I think it will be fantastic, but it's something we're watching very closely. And indeed, I was on a meeting this afternoon where we're talking about how do we best monitor outcomes at regional level to make sure they're being maintained. But ultimately, what we need to do, and I've alluded to this already, is change the training and change how HIV care is delivered. And I think what we need to do is increase everyone in medicine, everyone in social care, the sort of general principles of HIV care, expand that and actually condense management of complex HIV care, because as I say, we've got this very specialist care model. People with HIV come and see specialists at every visit, but the risk of serious HIV complications is tiny. The risk of serious issues on HIV drugs is tiny. So I think we need to condense our specialist services and work really hard to try and integrate HIV prevention and care much better across the wider system. So I finished on just a couple of closing thoughts, and I just wanted to point out, we've talked about stigma. One thing, thankfully, that is a relatively small issue, though not zero in England, is the issue of HIV criminalisation. But there are many parts of the world where this is a huge problem, including the United States. Now, the United States has pretty poor HIV outcomes compared to similarly resourced countries, and perhaps not surprising, they've got a very fragmented healthcare system. But this is a map looking at states in the US that criminalize HIV, and I just want to share this one example. This is true. This is a man living with HIV who's spoken at a couple of conferences that I've been at. I cannot remember what state he lives in, but in his particular state, the fact that he had sex with someone else. This is a man with HIV who is undetectable. He cannot pass HIV on. Indeed, he didn't pass HIV on. He had sex with another man who complained. He was prosecuted, even though there was no transmission. And in this particular state, I promise this is true, he has sex offender emblazoned across his driving license. We will never reach zero HIV transmissions, which we could if we're going to treat people living with HIV in this way. The other figure that always makes me incredibly sad is that almost half of the 1.7 million children living with HIV weren't even on treatment. And I think working of specialty, advance is so important, injectable treatment, fantastic. But when we can't even get the drugs we already have out to the people who need it, it kind of makes you wonder where our priorities should lie. And ultimately, my goal is we should have a vaccine for common sense. And if we injected that vaccine into all of our governments worldwide, then we'd be in a much better position. I shall finish there. Those are my, if I don't know if you'd want this size, if you want them, drop me an email as my email address. I'm on Twitter, often sharing updates related to HIV. And the final thing I want to flag is the People First Charter. So this is a website I set up at about 2 in the morning when I was very angry, attending a virtual conference, because some of the stigma is perpetuated through language. So, for example, to call someone an HIV infected person is really stigmatizing language. To refer to them as a person living with HIV is preferred. Now, this isn't unique to HIV. It's broad across medicine, person first language, not the diabetic, the person with diabetes, the schizophrenic versus person living with schizophrenia. There are so many other areas in medicine where this is important. But every year I go to a conference, there's always examples of inappropriate language use. So the peoplefirstcharter.org is specifically about language in HIV. We've got a very short guideline that's slowly being translated into lots of different languages. And it's a battle I will continue to fight until I don't see HIV infected person in the title of a presentation at a conference. Because if we can't get it right in the medical and research community, I really don't think we can ask for the general population to get it right either. So I shall stop sharing my slides and finish there, and hopefully we can have a discussion and some questions.
Thank you very much indeed, Zoe. That was absolutely amazingly outstanding. And my goodness, I have learned so much, and I'm sure everybody on the Zoom screen has likewise learned a great deal. Thank you very much for a very, very helpful, very informative talk. Thank you. So this is in memory of our dear friend, Chris Sanford. And I'm going to make this very interactive. I'm going to now open up to questions, but I'll perhaps start off to allow you to think of the questions that you may want to ask our friend Laura. But since we are fondly remembering our friend Chris, let me just ask you, Laura, first. Obviously, you worked very closely with Chris for a number of years. And so I'm perhaps a little keener to know more about what Chris did about HIV care, how he was supporting others in a similar situation, please.
Yeah, so how can I answer that succinctly? So from a sort of service level, as I mentioned, Chris was one of our first employed, we used to refer to them as patient representatives, now peer support workers. So not only did Chris have a function in terms of providing that peer support to people in clinic, he held us all to account. So we would have regular management meetings and Chris would be at the meetings. And again, I think our service remains quite unusual in that regard. So Chris would make sure that everyone in the clinic knew what was going on, knew what innovations there were, knew what activities there were to support people living with HIV. And he would hold us to account, and he would always, at the heart, everybody who works in the NHS has the best possible patient outcomes at the heart of what they do. But it's surprising how easy it is to sometimes lose sight of that, to sometimes end up in debates and discussions about service developments and funding and this, that, and the other. And Chris would always bring it back to what was important, always bring it back to the patient perspective. He did a huge amount of teaching. So, you know, sexual health and HIV have been relatively neglected topics on school curricula. I'm not going to get into the politics of teaching school children about sexual health, but even at medical school that teaching has been quite patchy. And I was really taken by some of the emails I received after Chris died from the University College London Medical School and various diplomas and masters where Chris would speak, and Chris was always one of the highlights of people's programs, because the value, you hear the theory and you get taught the guidelines, but then to hear the perspective of someone with lived experience of that condition is absolutely invaluable. And I think, as you mentioned earlier, he would hold the top levels to account. Not long before Chris died, I saw him at an event at the House of Lords. Makes my life sound much grander than it really is. We were at the House of Lords for the launch of a report about, you know, the challenges facing older people with HIV, and he stood there and there's some great talks. But Chris's talk, he never lost that fire. And he stood there and he gave this speech, and it was everyone in the room was, you could have heard a pin drop, literally. We couldn't have heard a pin drop because Chris's voice projected so much that you wouldn't have been able to, you could have dropped a bucket of nails, you wouldn't have heard it because Chris's amazing projection. But everyone in that room, and there were politicians, there were funders, there were commissioners, there were many people from the community of people living with HIV, but he still recognized that we still had work to do. He never stopped and thought this is enough. He never stopped and thought we've done this, we've got these excellent outcomes, U equals U, this, that, and that. He always recognized that there was more to do, and so he was an inspiration and a fighter right up until the end.
Well, Laura, he certainly was inspirational to so many people, and he certainly was a fighter. Thank you very much. So friends, if you want to ask any questions, just raise your hand or put it in the chat if you prefer, and I'll try and bring you in the time that we have left. But Laura, you talked about reducing the risk, you talked about prevention, and I'm keen to understand a little bit about some of the preventive work, but also when a person finds out that they are, for the first time, when they are HIV positive, what sort of support is available? What sort of support is available from the NHS? And you also talked about the other aspect of that biggest challenge, the age. And I wonder if you could just tell us a little bit more about particularly the support available to the people as they get older.
Sure. So if someone's newly diagnosed, again, that experience is going to vary, to be honest, because, you know, if you are diagnosed with HIV in a part of the country where it might be a very small HIV service that's only open once or twice a week, then clearly the support that you're going to get isn't necessarily going to match the support that you're going to get in a big city, and that's not right, but it is sadly the reality. Having said that, generally speaking, HIV services do an incredible job, and if I speak about what happens in our clinic, so if somebody has, firstly, when you have an HIV test, you can't say that someone is HIV positive at the beginning, because, you know, all tests can be inaccurate. So if you have what we call a reactive HIV test, the first thing we do is we confirm it. We confirm that as soon as possible, and then we can tell somebody categorically whether they have HIV or not. In our team, we have health advisors, and health advisors come from a variety of backgrounds. Some come from a psychology or counselling background, some come from a nurse background, but these are people who've been specifically trained to give people new diagnoses. Now, 15 years ago, there were health advisors everywhere. Sexual health services were incredibly well staffed, and unfortunately some of the cuts in the public health budgets mean that not all sexual health services have health advisors anymore, and that's one of the reasons why things have got a bit patchy, particularly in some of those areas where HIV is less common. But we do have a team at More to Market. They are a wonderful team, and they will see people and speak to them and talk them through some of the information I've shared today, talk to them about prognosis, talk to them about transmission, talk to them about whether they need to test any other members of their family, if they have children, for example, or sexual partners. An offer to see our peer support team is made right at that point as well. We link people in. We have our in-house peer support workers. We also have the fabulous Bloomsbury Patient Network, which is a network of people living with HIV who access care, and they provide courses and forums and webinars to help support people with HIV. People get a medical assessment very quickly, and nowadays they'll get offered the option to start treatment immediately. So people can be started on treatment on the day of their confirmed HIV diagnosis. And that gives people a sense of control. To be diagnosed with a condition, but to start treatment for it straight away can be a really empowering thing. Then there's a wealth of information online. We've got a number of fantastic community groups. And again, there's a real pattern emerging here you may be spotting, that we rely so heavily on community and third sector organisations to provide that accurate information, because again, information that is owned by and led by people with a condition is always going to be more informative, more supportive and more compelling than anything that I could write as a physician.
Thank you.
Aging, you mentioned, that's a good question. I won't dwell too long on this. This is a challenge we're facing, and this is where we kind of probably should have thought about this and changed what we were doing a little sooner. But what we do is we work very closely with primary care. The days of people refusing for us to communicate with GPs, it's still an issue for some people, and they may have had very negative experiences, and we support them as much as we can. But most people with HIV actually get annoyed if I can't see the cholesterol result from the test they had at their general practice the week before. So really, I think the issues facing people aging with HIV, beyond some of the residual stigma, and there are some particular issues about medication interactions, but really it's the same challenges that everyone else faces. How does any country with an increasing proportion of older people provide safe care for those people? So it's the same challenge that faces the rest of the health and social care system, and I certainly don't have any magic answers to that, sadly.
Thank you very much. So quite clearly some wonderful stuff happening. Thank you for sharing some of those good works that is happening. But I will come on to the stigma in a moment, Laura. But I wonder if you can just tell us a little bit more about other concerns that are voiced by those who test positive for HIV, please. And also, how do we mitigate those concerns at very early stages, so that their experience of services is positive from the moment go? I know you have already said that the experience may vary from service to service, but and you don't have a magic wand, of course, but it'd be good to understand how are we mitigating some of those concerns.
Yeah, I mean, I think we've probably touched on most of it. I think people are concerned about whether or not they pose a risk to their loved ones, and it's I have to shift. I still think of myself as a junior doctor in my head. It's ridiculous, isn't it? But I have to accept that I'm not. I'm a doctor with many years of experience in this field now, and I think back to the sort of early noughties when I first worked in HIV medicine, and you would speak to somebody who's newly diagnosed, and I remember cases of people just being slumped on the floor in tears, people sobbing on my shoulder, and you just generally don't see that anymore. It's not across the board, but on average, most people have got a better idea now so people tend to already know that they will live with HIV, not have their life ruined by HIV. People actually often do know about the U equals U message, but you still get questions. Can I hug my grandchildren? Can I cook for my family? And you can address all of that with adequate information. I think people worry about confidentiality, and I think there we need to reassure people that the NHS is actually pretty damn good at keeping information confidential. It's something that's really embedded, and I think giving people confidence to trust the whole healthcare system. I think historically people have believed that HIV and sexual health services will protect them better, but that's what we need to move away from, because again, we're not going to integrate HIV care and improve HIV testing if we don't embed it further. I think knowing someone else, and the thing is, I think with some conditions, it's likely you've got a friend or family member who's had that condition or lives with that condition. HIV is still a relatively uncommon condition in England. So the ability to put people in touch with peer support organisations, Bloomsbury Patient Network I've mentioned, there are other organisations where people can perhaps chat to somebody in an entirely different city if they want to, and have that conversation and hear from, and again, it's going to be my answer to everything. Peer support is absolutely critical. But I think I just noticed, Ketan, there's a couple of specific questions in the chat that I wondered if we could just touch
please.
on. So,
Yes.
Svet's asked about explaining about HIV infected person. I think it's the terminology infected. To say something's infected it sounds like a boil, or it's just quite negative terminology to apply to a person, and it's one that it's back in 2015, actually, that UNAIDS, big global HIV organization, first suggested that we should stop using HIV infected. And it came from the community. So it came from people living with HIV saying, I don't like being called HIV infected. I don't like being, I don't like that term. Whereas to say living with, or some people prefer the term thriving with HIV, I am a person who happens to be living with that condition. So that's, I'm not sure if I've explained that very well, but that's the history behind it. I'll give you some other examples. So we often used to say, because we know that a major transmission route globally is transmission from mother to baby, and we used to call that mother to child transmission, which puts a blame on the mother. But in some situations, a mum may have been HIV negative at the start of pregnancy, but her partner may have had sex with somebody else, acquired HIV, passed it on to her. And the idea that that's the mother to child transmission, that's again another thing that the community raised. So we now refer to that as vertical transmission. Probably not the best example I could have chosen, but again, it's all around just using sort of kind person first language. We try and avoid the term patient often where we can, and refer to person, individual, and that kind of thing as well. But it will change. That what's considered appropriate language in 10 years' time may be very different to what we consider appropriate language now. And we know that things, language, around gender, around ethnicity and race, around sexuality, all of that evolves and changes over time. And I think the key message is listening to the people affected or living with that particular characteristic, to let them choose the terminology that they prefer.
Right. So within a couple of minutes that we have left, Laura, just very quickly, can I just ask about the biggest challenge that I guess we have in this particular area, stigma. And of course, you had some good slides on stigma. You have referenced stigma quite a lot in your talk. And I wonder, how do we crack this? I know mental health has had a lot of publicity around destigmatizing that particular area. And I wonder if there are lessons to be learned from that. Of course, you were referencing earlier in your talk that people living with HIV also are more likely to have mental health problems. And perhaps, you have double whammy in sense, don't you? And it would be good I know you're doing absolutely amazing at every single event, every single function, every single opportunity to break down those stigma. But what can we as a society do to do that as well?
Goodness me, I mean, you just finished on a sort of PhD thesis type question, Ketan. I mean, I think it's about making every opportunity count. That's a bit of a mantra in the NHS. So it's about meetings like this. It's about making sure, I really think we will never get it right if we don't get it right in health policy. So a good example actually was so the monkeypox, which has now been renamed Mpox outbreak we experienced recently. And in some of those initial communications, there was a lot of negative language, you know, Mpox infected people, people talking about Mpox spilling outside gay communities into women and children, and this sort of negative, blamey spreading of infection type language is one that, you know, that was being used last year by our own national health body. So I think constantly challenging politely, reminding kindly, and correcting appropriately is important. I think it's about ensuring that we address this from the beginning. So we do need to make sure that even if it's not specifically, that the consideration of person first language is embedded in school curriculum.
Right.
I think we need to ensure that when we talk about training in the NHS, that we use specific examples, that we use some of our diversity and governance training to make sure that we use examples from mental health, from HIV, from obesity services. And I just think by sharing in a caring way, then eventually we will get it right.
Thank you very much for that. Hopefully, we will be able to do better, all of us as a society. A final point, very quickly, 10 seconds. What is the single message would you give all of us on this call, please? So
I think my single message would be, other than U equals U, and let me share a very brief anecdote. Sorry, I know we are out of time, but give me this. So I saw, this is a true story. Like I tell untrue stories, I always tell the truth. This is definitely a true story. And it was a woman living with HIV who re-engaged with our service after a 10-year hiatus. She'd been disengaged from care for 10 years. As it happened, she was some people with HIV, they actually controlled the HIV quite well on their own. So she still had a pretty healthy immune system and a fairly low level of virus. So I said to her, what you know, out of interest, welcome back, of course, what is it that triggered you to re-engage? And she'd met a man online, sort of dating website, app, whatever. He's HIV negative. He told her about U equals U. He told her that if she's on effective treatment, she couldn't pass HIV on. And that's why sharing the core information about HIV, not just to people living with HIV or people caring for people living with HIV, but to the whole population, is so important. So U equals U, I think, is an absolutely key message. And I always say to anyone, if you haven't had an HIV test, please do, because you just need to have had sex once to have acquired HIV. And if you've never had a test, get tested, and encourage everyone you know to test as well. So 2 messages, I'm afraid, but 2 very important ones.
Fantastic, powerful note to finish this on. As I say at every single session like this, that 1 hour is never enough. But you know, this is just the beginning of our conversation, and I'm sure we'll be able to have a second part of this conversation in not so distant future. But very quickly, let me bring Ali for her closing remarks, please. Thank you.
Thank you, Ketan, and huge thank you to Laura for what was really informative and thought-provoking presentation and discussion. Lots for us to take away and think about. And also just thank you, Zoe, Dorothy, Laura, and Ketan, for sharing your memories of Chris. He sounds like a very special person who leaves a huge legacy. You know, with his passing, and so thank you to everyone also for coming along. And just to let you know as well that we will have a lecture on the 29th of March. That's the next lecture, and that will be looking at COVID recovery, and we'll be circulating full details within the next week or so, alongside the recording of this event. So thank you for everyone for this evening, and we hope to see you again soon.